Hey there, welcome to Hump Day Happy Hour, hosted by Dentists in the Know. This is the webcast where dentistry meets real talk, real news, and just the right amount of sarcasm. We are pulling back the curtain on the industry, talking to the experts, the innovators, the everyday clinicians, the ones that are out there doing the work. There's no fluff, no filter, and there are definitely no sales pitches disguised as education. If it's happening in dentistry, from clinical insights to regulatory curveballs, or maybe the latest scandal at the ADA, we are probably already talking about it. And yes, we are bringing the goods. So whether you're a seasoned doc, part of a dental team, or industry, a curious consumer, or maybe you're just here for the banter, we welcome you all to the show, because around here, we are not just in the loop, we are in the know. Hey there, Dinks. I'm Dr. Jeff Horowitz, accompanied by two amazing clinicians and friends, Dr. Chad Duplantis and Dr. Jennifer Bell. We created this platform to make the dental world just a little bit smaller and a whole lot more fun. So today we have a great guest. Greg Grobmyer is here from Blair and Associates, and we've got a phenomenal topic, one that always resonates with everyone, and that is dental coding and some of the changes that are coming up. So I am really excited because this is actually the first time I met Greg in person. So excited to be involved in the banter. And my friends, how are you doing tonight?
Great.
Doing great, Jeff. How are you?
I am good. I'm in a island kind of vibe.
I see that.
Yeah.
Are you going on vacation tomorrow or something?
No, hell no. I'm working tomorrow.
Of course you are.
Yeah.
And Friday and Saturday.
Not working Thursdays to working Thursdays. Yeah. I'm going
life in the fast lane.
Yeah. I'm totally working in the wrong direction. But hey, I'm still in a good mood.
Well, I love the vibe because here it's been raining pretty much for 3 days in a row. And I was in Texas last weekend for an event, visiting my family, and it rained pretty much the entire time that I was there. So I'm going on like 7 days of Jeff didn't get that. That's okay.
Yeah.
Greg got it. All the kids are doing this. Anyway, that's a subject for another day. But I am now on like 6, 7, 8, 9 days of rain, and I'm kind of sad.
You're over it.
Yeah, I had to do a pop of color, but it's still a sweatshirt because the idea of putting on something tropical, I don't think it's going to solve my problems.
Yeah, I don't know. I'm just trying anything because really my life's just shit.
I applaud the effort. I really do. LA would have really
needed that laugh. I needed that laugh. That was good.
Yeah.
That was good.
Well, Chad, how you doing, bud?
I kind of, JB's sentiment is about the same as mine. I was actually supposed to meet up with her husband and son last Friday, and about 6:30 in the morning, we were having conversations about the weather, and it was not a good day. And so I didn't get to see them last weekend. I was really sad about that. But man, this morning, I mean, it all of a sudden, just like Texas completely skipped fall. We went straight to winter. I took the dog out this morning and she was like, nope, let's go back inside. I'm done with this. It's too cold. I mean, it's just all of a sudden it hit. And the wind today has been like 40 miles an hour. It's been just nuts. I feel like
nice.
I shouldn't even make this joke, but I was going to say, I feel like I'm in Jamaica, but those poor people, they really,
that's no
they
way.
took it on the chin today. So our thoughts and prayers do go out to our friends in Jamaica and those in the Caribbean. But man, everybody down there is getting beat up. I guess things could be a lot worse.
You know, it has stayed the same since summer. The Giants and the Cowboys still suck.
Yeah, that's been very consistent.
Very, very consistent.
Very consistent.
Actually, I'd like to disagree.
Okay.
The Cowboys, they have the number one offense in the NFL.
And they still lost to the Panthers.
Yeah.
Theoretically. So I think it's going to show you that you can have the number one offense and the number 32 defense, and your result's going to be pretty much mediocre, because I don't think the Cowboys will be good again until Jerry Jones is gone.
Yeah.
And I don't
Do
even
we
know if they'll be
have
good
a-
then.
Do we have a favorite for the World Series?
You know,
I
I just
could,
love watching a
honestly
pitcher who
care
can hit
less.
home
Sorry to
runs.
my Toronto and LA friends. I could care less.
Yeah.
Okay. Well, we just alienated some percentage of the audience, but we're so happy to have everyone else who's not a Dodgers or
And by the
Toronto
way,
Blue
to the
Jays
rest of
fan.
our audience, you all suck too.
Yeah.
Actually, you know what? I'm going to make a choice right now. I
Make
hope
a choice.
Toronto wins.
There you go.
I hope Toronto
I gotta
wins
go with
because you know what?
Toronto.
They haven't seen it in a while.
I'm not an LA fan for anything. So
There you go.
yeah.
I hate the smog. I just,
Yeah.
So
if we're alienating everyone, let's just go ahead and get the West Coast off the table, you know?
That's right. They don't watch the show anyway.
Yeah.
We're fine.
Yeah. Exactly. We even made it later for them and then they didn't watch. So
yeah. Fair enough.
Okay. We love you, West Coasters. It's just the West Coast, not so much. So anyway.
Heart.
I'm in a little bit of a mood, if you can tell.
Heart.
Yeah. Hey. Yeah. You want to talk about it? Do you need to talk about it, Jeff?
No. All good. Yeah.
Well, I
good.
just spent 3 weeks doing a webinar series with Ada, which is one of our educational partners. And it was all about finances. So talk about just like really getting yourself in a mood every Tuesday for 2 hours. I would talk about KPIs and financial management of your practice. And then ultimately we talked about transition. And the whole time I'm like, man, this is so much work. It's so much work to manage a practice and to manage all the different entities and things that are happening. We don't give ourselves enough credit for all the stuff that we're doing on any given day. So
I was so glad that you agreed to do that because it's just so needed and sometimes it's a tough pill to swallow, but it's just such valuable information. Is that something that we're at some point going to be able to replay or how
so
can
at
people
least for
access
the
it?
next 60 days, it's on demand, I think, through Ada Education. So if you go to Ada Education and look up virtual curriculum, it's pretty much me that's left because they're really kind of winding down virtual for 2025. So the 3-part series is there, and we talk about understanding the metrics. We talk about what we can optimize in our practice to make that better, which includes insurance, which, Greg can contribute to that conversation. And then
does he know something about insurance?
he filed a claim one time, and I think now he thinks he's an expert. So whatever. And then the last is transition. And I think that really appeals to everybody because the point of the webinar is that conversation starts really early in your journey. Because my analogy is if you buy a house and you spend the next 30 years destroying it, putting holes in the walls, never fixing anything, shit all over it, right? When you sell it, do you think that asset will be worth more or less? Maybe in an up market, you'll see a little bit of value, but the likelihood is it's not going to be worth as much. And you're going to have a really hard time finding a buyer for that. And our practices are very similar. We're constantly working the practice, not just because we need to earn a living, but we should be building an asset that at one point, we can turn that key over to somebody else and sell it for at least what it's worth. But in an ideal world, we've actually built an asset that has grown in value, and then our net worth appreciates along with that as well. So kind of using that analogy to help folks understand that process starts the day you open your practice, and you're constantly investing in building into that. And unfortunately, we all know people who that transition happened way earlier than they had hoped or planned for, from disability, divorce, moving, medical issues. There's a lot of things that happen to us during life that changes the trajectory we think we're on. So we can't just wait to build the thing that is an asset
or maybe getting lured in, by this really attractive sounding offer, thinking this is my perfect opportunity to exit, and then realizing, well, wait a minute, it's not all it was cracked up to be.
That's exactly right. So anyway, I thought it was a really great series and seemed to be fairly well received. So if anybody's interested in that, I think it should sit out there for at least the next 60 days. And then maybe we're working on our,
I, for one, am going to watch.
We're working on our webinar series for Dinks in 2026 in the calendar. So first off, if you have any suggestions, pop them in the comments or send me an email. But in addition, we're going to we're going to start showcasing more Dinks education from the host. So I think that will be fun. Yeah.
Can I say something?
Yeah,
I'm going to come clean. Since you were talking about KPIs and everything, I'm gonna share a little story real quick.
Okay.
You asked how are things going, and I could say they're going great, or I could say they've been utterly shitty lately. And the reason that I choose to say that they're going great is because we've really honed in on our KPIs, and we've honed in on what makes our practice tick. And over the past 3 weeks, we had a leak in one of the rooms that required all of the flooring to be replaced, which was freaking awesome. That was fun. Last week, we came in and we had the AC go out. So they came out and they fixed it for $1,000. And then they said, you really need a new AC unit. And if you decide to do that within the next 30 days, we'll give you $400 off of the new AC unit, because I know you weren't really prepared to do that today. Well, 2 days later, the temporary fix shit the bed. And so we got another AC unit. And then Monday morning, I showed up to work and I had a gusher coming up through our front lawn that was on our side, so not city related. And we had to have the main line to the practice replaced. So shut down water, lose production for 5 hours. And the reason that I'm telling you all of this is not to feel sorry for me, because you know what? I don't want you to feel sorry for me. Shit happens, right? It happens at home. It happens at work. But the beauty of it is when you really hone in, I cannot say that 5 years ago, 10 years ago, we would have been prepared for 3 back-to-back major expenses to happen to the office.
Yeah.
And right now, honing in on everything, 3 back-to-back expenses, not overpaying ourselves. I'd like to say that we pay our staff very fairly. I don't know that they'd agree, but who the hell knows anymore? But the thing is that shit happens, and we were able to fix the shit that happened. And it's just by managing your money, managing the way that your expenses run through and out of the practice, maintaining enough in the kitty to be able to take care of these things. And you know what? Those were 3 events that could have caused major stress 5 years ago, 10 years ago, hell, maybe even 2 years ago. And it was just like, you know what? It happens, pay it, move on, don't worry about it. And so, that's the benefit of listening to these talks and lectures that Jennifer's giving, and those types of lectures, is that you kind of hone in on what's really important to keep the practices going, what's really important to keep you going, and you're covered when shit happens.
Great message. I love
Well, we get into survival mode too. Like when our KPIs get super out of whack, a lot of times it's survival. It's the overhead, it's staff costs, and we're just constantly feeling like we're feeding the machine until finally you just have to take ownership to say, it just is not there. So you have to, it's that book, Killing the Sacred Cow, right? You have to eventually say, I don't want to lose you as a valuable employee, but you're outpacing, your salary is outpacing what we can afford. So unfortunately, we're just going to have to say, this is what the practice can currently provide to you as a salary. If it's good enough, awesome. And if it's not, then we wish you the best of luck. And there are really hard conversations that come with that when we have those. But when we understand our numbers, we're more empowered to say that, to have those types of conversations. So anyway.
I love it. I cannot wait to watch. I'm excited. I know this is your wheelhouse, so I just can't wait to hear it.
Let's go.
Do some news.
I would love to.
Yeah, we're just talking and rambling.
Are we ready?
Yeah.
But I'm gonna
and drop you down. You wouldn't just take me out of the picture altogether. All right. Well, 2 big stories. Well, I guess a couple. One, ADA SmileCon was last week, or just finished up, I guess, within the last day or so. Lots of activity, flurry of activity. New president has been named. I think there was a clear message about fiscal responsibility and being more transparent. We'll see how that translates over the next year with new leadership. But I think that everybody's intentions were really good. So hopefully we'll continue to see the ADA flourish. In other news, this kind of wasn't on my radar. I totally missed it. And so for that, I apologize, because I really do take a lot of pride in bringing you guys news that's really relevant and current. But I sort of missed this massive merger that happened with the dental examiner boards between CDCA, REB, and CETA. All joined forces, became the American Board of Dental Examiners, ADEX. And now that represents almost 98% of dental licensure exams and dental hygiene licensure exams in the US. I watched an interesting podcast on Dr. Bicuspid about that merger from the president of ADEX and sort of what their overall scope of joining forces together. And I think that there's a lot of good things that will happen. Certainly, it standardizes licensure amongst all states. And in theory, we should have clinicians that are of equal level of competency throughout the US. So I think that's a plus. And he also did state that for the last 3 years, they have not raised their prices for licensure examinations, which is a huge kudos to them as well, because there is financial compression. And I think he's basically highlighting that this merger would allow them to continue to keep it affordable. I do worry that now with that final merger, that's 98% market share. In my books, that is a monopoly. And so it does become a little bit more concerning that could allow for increased and unchecked price increases that are unchecked, oversight and overviews, and changes in licensure examinations that are somewhat unchecked as well. So hopefully, there's transparency to be had there. And certainly this plays quite well with the compact and other advancements that are happening in the licensure space to allow freedom of movement for all clinicians. So we'll continue to see how all this plays out. The last little bit of news is important because of who our guest here is this evening. We wanted to give you the 2026 update, a few highlights that I think most GPs would be interested in. There are over 60 code changes, including 31 new codes. I'm sure Greg will highlight some of those new ones for us, but these are just a few that were interesting to me. Therefore, I'm inclined to share. We're now going to see a code for point of care saliva testing. I love that we're moving towards the diagnostic testing codes. I really hope insurances also start reimbursing for that. When we can start doing rapid testing, saliva testing, perio testing, et cetera, we can get real data very quickly to patients, looking at bacterial loads and giving them guided advice on next steps. So I love the movement and any way towards laboratory testing chairside and giving patients quick information that they can digest and process. There's a new code for testing for cracked teeth. This will go right alongside with pulp vitality testing. So you'll be able to also code for testing the cracked tooth, which we all know probably includes a tooth sleuth or some type of biting mechanism. Maybe it's an intraoral scan to look at the occlusion to see if you can figure out where some of the pain symptoms may be coming from, but we can now code that as well. A duplicate denture code is also on the books, which I love because most of my denture patients come with multiple dentures in their treatment plan because we want to make them a really great first set. And then we want them to either digitally store that really nice denture, or we would like to go ahead and fabricate them a backup set that they can keep available at the house. So now you have a code that you can submit to insurance for that duplicate denture. How that will play out with frequencies, I'm sure Greg can provide us a little insight into that. I'm not sure. I would imagine they all fall under the same frequency code, but at least you have a billable CDT code that you can bill and you can pass that charge along to the patient. There is scaling and debridement around implants with peri-implantitis. So now we have better coding for when we open those areas up to get around those implants and try to get them nice and clean. So that's an improvement, I think, as well. And then finally, cleaning and inspecting the occlusal guard. We do this as a courtesy pretty frequently. Patients come in for recare visits. They bring their guard in. We check it out. We check the bite, make any adjustments, smooth it up, and we throw it in the ultrasonic and clean it. That does take staff time and it does take doctor time. And now there is a CDT code that might accurately reflect that. So just a few highlights from the new codes that will be coming out. Of course, you should always get your updated CDT coding book to get the full review. And then, of course, I'm sure our guests can talk to you more about coding with confidence so that you can be optimizing these codes to best suit the revenue and treatment planning for your patients. And with that, that's the news.
Riveting.
Right?
Riveting. Absolutely riveting.
I know you're just a real CDT code junkie, aren't you?
No, actually, there was one in there that well, duplicate denture. I was trying to figure out how and when that would be appropriate, but cleaning and inspecting night guards, love that. That's huge. But there was something that came up today where, somebody was talking about, oh, it was an associate, like, oh, this work was done by a dentist and, how do I charge for it and this and that. And the comment, it's made by astute people all the time, but we're the only profession that feels that we shouldn't be paid for certain services that we provide. And when we look at that, we look at the dental reimbursement versus the medical reimbursement, which is a lot different. Like if somebody comes in and does a knee replacement, it has to be replaced 6 months later. Is medical insurance going to pay for it? Absolutely, they are. Is dental insurance going to pay for it? Hell no. Hell no. But the thing is that, you've got two different maximum alloweds and you've got, a hell of a lot more money going into medical insurance and all that stuff. We just had this conversation 5 minutes before we started. I mean, our medical insurance rates just went up 20% next year. Screw that.
Well, let's do this because we've kept our guests waiting for a long time, and I think
keep waiting. Damn it, I don't care.
No, I like the guy,
Greg.
Chad. Despite what you said about him, I like him.
You just met him. How can you like him? I'm the one that knows him best.
Well, I didn't stop you from talking bad about him.
I'm teasing. You want me to introduce our guest?
Yes, please introduce him.
All right. Hey, Jeff, I can't walk and chew gum, so you bring him up, okay?
You got it.
All right. Our guest tonight is Dr. Greg Grobmyer, and I hope I said that correctly, but anyways, I'm going to say it that way, and he can correct me later.
I thought you knew him best.
I have been certainly called worse, so
okay,
we're good. But yeah, Greg Grobmyer.
Pronounce your name for me.
That's right.
Grobmyer. Okay.
Yep.
I thought it was Grobmyer, and Jeff called you the Grubmeister earlier, so I just wanted to make sure that I said it correctly.
Believe it or not, my dad went by Grub, Grub.
I'm sorry.
And so,
I'm sorry.
Yeah, we all call ourselves something different. It's one of those weird names.
But anyways, Greg practiced clinical dentistry for over a
it's always the intro.
Are you all hearing me or am I cutting out?
No, you're cutting out.
You're cutting out.
I can do my own.
Every time I switch over to the intro.
It is.
So I'm not going to switch over to your intro. And I'm just going to say that Greg practiced clinical dentistry for 10 years. He had an issue from chemotherapy that prevented him from practicing dentistry further. I'll let him talk. It was with his fingers. Yes, like Jennifer said. This isn't show me the money. This is Greg's fingers got injured from chemotherapy. He lives on a beautiful mountaintop in Tennessee. Greg, how many children do you have?
I have 3. I've got 2 that are college age and 1 that's a 5th grader. So I've got the gamut.
That's a big spread.
Absolutely.
Are you telling us you got an oops baby?
No, I got a second marriage restart.
Okay.
That's what I got. I thought I was done, And then we decided to start again. And so be
Well,
it. It couldn't be better, but I'm now spending my evenings relearning long division. So
Yes.
well, hey, this is the intro that I'm going to give you. Greg decided to pivot, and Greg decided to start introducing and interjecting himself into the dental insurance coding world. You took over Charles Blair, right? I mean,
well, I didn't. Well, he was my mentor. You make it sound
Yeah.
like it was a one of these things where I bought him out and had him taken out or something. But no, I got to work behind the scenes with him for 5 or more years. I was the ghostwriter for Dental Coding with Confidence and the Insurance Solutions newsletter for many years. And as he got on up there, he was getting into his upper 70s. He began to kind of step back, and I began to kind of step into the more forward, front facing stuff. And so doing the coding and the consulting and the flying around the nation, speaking and all that kind of thing. And then, so that's as he stepped out of the limelight, he pushed me into it. So there we go.
Well, I'm telling you, it was a great pivot for you. You've done wonderful things for the profession and for yourself. And at every conference that you are at, I promise you that Greg will be there, because we have passed each other in the hallway on numerous occasions at the Hinman, at Texas, and then most recently at Florida. But honestly, Florida was the best because we got to sit at the cool kids table with Ashley Clark, yourself, myself. We had Kelly Tanner there, and we just had a hoot. And it was great to actually really sit down and have a nice conversation with you and learn about what you do. But I encourage everybody, if you're at one of these big meetings, to listen to Greg. He can do wonders for your practice. So that's the intro that I'm going to give you. You're a hell of a guy, and we're glad that you're here. So thank you, Greg.
Kind. I greatly appreciate that. And it's been, to summarize, I went through a cancer battle. It was colon cancer. I ended up going in, talking to my doc about acid reflux, and found out I had colon cancer. Not the day that you want to have, but I ended up having, same day as colonoscopy. I woke up and they were like, "Hey man, we saw this thing. It's got to go. Would you like to do it right now?" Immediately got put under, took the whole right side of my guts out, and now everything I do is half-assed from this point forward. So, but that's yeah, there we go.
It's worked for Chad for his whole life.
Well, there you go.
Yeah, and he has his full ass.
Greg, that's debatable.
I got to use that.
How old were you when all of this
36. No family.
And how long you've been practicing? 10, 12 years?
Yeah, 10 years. And so this is, lesson number 1. Guys, get good occupation specific disability insurance policies. I would not have survived without it. And so absolutely that helped me transition. I had been the recipient of coaching and consulting for the whole decade I was in practice. My senior doc was kind of really into that. So I started hitting the ground running day one with all that. So I'd had 10 years under the belt, and I switched over and did that for a long time, and then wrote for the dental industry for a long time. I got to write not only for journals and blogs and websites, but also got to write a lot of consumer facing stuff for like Reader's Digest and Men's Health and, New York Magazine. It was pretty cool. Got to do some kind of weird, fun stuff in addition to just, things that are kind of strict and heavy and clinical. So that was a blast. And then after kind of exiting coaching and consulting, I eventually worked my way to Dr. Charles Blair. And so there we are. So I've been with him for quite a few years, and I'm now writing Dental Coding with Confidence. I spend 3 months out of every year locked to a computer with a ball and chain, rewriting this 560-page manual. We rewrite it from beginning to end. I get the updates in about May, and then I spend 3 full months rewriting the entire book, cover to cover, updating everything that needs to be updated. And it's a lot. And so if you're not familiar with that as a resource, Dr. Blair started that over 20 years ago now. Coding with Confidence has been out there, and it gives you essentially what CDT gives you. It gives you the list of the codes, but it also gives you how to use them in respects to insurance, what to expect from payers, what narrative needs to go with it, what documentation needs to go there, what needs an image or things like that. And so working a lot with the payers and going through all the different plans and kind of reading what their claims criteria are and picking and choosing all that stuff and putting it into a good resource that you guys can kind of look at. And so there's a lot of information in that book. You can look up every single code and it'll tell you how to use it properly. So
Greg, do you guys still do the medical code books as well?
We do. In fact, we're in the middle of that. The medical coding updates at a different time than dental, and so there's a lag time. So we're working on an updated version of that, but it's probably going to come out mid-year, instead of it coming out beginning of the year this time. So so it's a little bit of a lag on that, but yeah, that's a heck of a book, man.
It's
that's
a huge book.
It's a doorstop of a book. It's giant. And so we also have an administration book and a documentation book. So we've got a lot of resources and each one of those are updated and rewritten every year. So I'm doing a lot of this and I'm doing a lot of talking and coaching and consulting and stuff. So that's how I spend my time. I'm a stay-at-home dentist. There's not a lot of us.
I want that job.
It's pretty cool. I actually like it. I really
Your
do.
neck probably feels better.
I don't know. I'm doing this all day long. So
that's true. Carpal tunnel.
Well, Greg, would you share with us, if you would, maybe some of the highlights of what this year is going to look like, or what 2026 is going to look like, and maybe give us a sneak preview.
Absolutely. I think JB kind of covered that at the beginning. So I think we're good talking. No, I'm just kidding. No.
I stole his limelight. No way.
No, but you did hit on some of the ones that really, I think, are going to be significant for this year. But there's one big chunk that you didn't hit.
Let's do it.
And that is, well, a few things like D180 is updated again. That is a seriously underutilized code. That's that comprehensive periodontal evaluation code. That's one of those that just simply incorporating that appropriately into your practice is one of those things that it's work you're already doing, but you're not getting paid for. And simply learning how to integrate D180 properly into your practice is going to make, 15, 20 bucks on every single patient that has any type of periodontal considerations. And it's not just a new patient exam. It's also for recare. And so you just have to know when it's appropriate to use it and how to use it. So that one's updating again, a little bit of a language change, not anything terribly significant. The saliva testing point of service, I think was, you kind of addressed that. They've actually we're working with one particular company that it's literally using your cell phone. You're not even having to buy a piece of machinery. You are doing saliva testing. It looks kind of like one of those at-home COVID tests. And so you're doing the little things with
on your phone. It's good.
And it's amazing. You do it. Yeah. You're taking a picture of like a reference color chart, and then you're taking a picture in the same lighting of this other thing, and it's spitting out all kind of great information. You're going to be able to do point of service testing for diabetes. For, the presence of pathologic bacteria associated with periodontal disease. So we're going to be able to kind of say this patient has perio because they have the right bacteria in their mouth. That's going to be significant. And as it expands more and more into the medical things, we really are physicians of the mouth. And I think this is going to be one of those things that is going to kind of promote that. It's going to point that out. So that's a big one. Preventive resin restorations. That's, people have been doing sealants forever, but if there's a little bit of decay in there, they've had to kind of adjust. If it didn't go into the dentin, it's this preventive resin restoration,
which no one covers.
Dentin, yeah, exactly. And if it did go into the dentin, it's a filling, completely doing away with it. No more PRRs. If there's decay, it's a 2391. It's a posterior one surface component, which makes sense.
Yeah.
Nowhere else in the code set is it talking about how deep the decay goes. If there's decay, it's a restoration. It's not a preventive anything. And so that makes sense. Duplication of dentures, you just kind of discussed that. And I do think that's pretty interesting, especially in the world of 3D printing. Right now we're 3D printing one and you can, you hit print, you got two. It's so essentially that's the code that when it's not all the steps that are involved in the initial construction, you're able to do this other thing.
That's right.
And I can't tell you how it's going to be covered yet. I wish I knew.
Yeah.
Okay, so Greg, I'm paused.
Yes.
I'm going to pause you right there because I have a question that I think it's burning for me, and I'm
Go
sure it's
for
going to
it.
be burning for some of our listeners too. Codes are one thing.
Mhm.
Insurance coverage is a completely different animal. Am I correct?
Totally.
So
Completely.
what are we doing to fight this? Because we've had codes for a lot of stuff that we do that you can put it in there, you can charge whatever the hell you want, but is insurance going to kick it out or are they going to pay it? So how can we combat that?
Two things here. Okay. First, the purpose of CDT. They're not insurance codes.
Of course.
So CDT, if you look at the beginning of the book, if you open up the CDT manual, it talks about the very first sentence is
Chad doesn't read, Greg.
Well, let me
Dumb
read
it down
to you.
for him.
It
Yeah.
literally says the CDT code supports uniform,
Am I from
consistent, and
South
accurate
Carolina?
documentation of services delivered. And that
Yeah.
happens to be used for things like processing dental claims and talking to each other. But it's essentially the legal language of dentistry. If you do a certain code, that means you took these certain steps, you did these certain things. And so you're able to document that. And that's not tied to reimbursements. Okay. That's a totally separate thing.
Yeah, but
Now,
the
the
legal
second-
code of reimbursement says we ain't going to reimburse unless there's a CDT code associated with it, and that doesn't mean we're going to reimburse.
Here's the second part of it. Okay. What is dental insurance? Dental insurance is not insurance. It is a defined benefit plan. That means there are a bunch of people in a smoky boardroom somewhere who the employers are saying, we want to design this plan so that these particular things are covered and these particular things are not covered. And these things are only covered in these certain situations. Just because there is a code for something doesn't mean it's going to be covered. And also just because there is a procedure, it doesn't mean that it's going to meet the plan criteria, even if they clinically need the procedure. You were talking about that knee replacement thing, and you said, dental absolutely wouldn't cover that. Well, first off, they're not going to cover a knee replacement, period.
Well, of course. But,
It's good to put that. We want to dispel any misinformation from this show.
That's right. No knee replacements in dentistry, but no crying in baseball. We mentioned that earlier.
Yeah.
But as far as the plan criteria goes, they're listing it out, man. You've got to have this much tooth structure loss before we'll call it a crown. We're going to have this much bone loss before we were going to say that it's okay to reimburse that for Perio. Doesn't mean they don't have it. Doesn't mean the patient doesn't need it. Doesn't mean that it's not clinically justified. Okay. It just means that by the plan design, they've got certain things that they're covering in certain situations and certain things that they don't. I mean, one of the codes that we're talking about that I think is a big one this time is that cracked tooth syndrome. Mm-hmm. And the reason why is because you've got language in these plan documents that has certain exclusions, and there are things like qualifying for a crown. A posterior tooth has to have greater than half the tooth structure gone, or it has to have a cusp that's undermined. And it also either has to have new decay or extensive recurrent decay, prior endo, or evidence of cuspal fracture. If you just see a crack on a tooth and it could have this giant amalgam in there and you got little crack lines coming off the side of it, most of us clinically would go, that needs a crown. Okay. Under most insurance plans, however, unless you've got one cusp that hurts when you tap on it or press on it, which is the definition of cracked tooth syndrome, they're not going to cover it. If there's not missing tooth structure that's significant, okay? If the whole tooth hurts, that might be endodontic. If it is just one cusp, however, then that's probably a cracked tooth. And that's justification then for getting a crown. They also say they're not going to cover crowns for attrition, abrasion, erosion, abfraction. Those are things that are just exclusions. If you've gritted and grinded your teeth down to where they're flat, I'm sorry, they're not going to cover your crowns. You need them clinically, absolutely. Increasing vertical, that's another thing most plans have as an exclusion. That's not a reason they're going to pay for crowns. And so knowing these plan documents and knowing this language and knowing what the exclusions are is super important. But this cracked tooth syndrome testing code is going to allow us to be able to say, hey, we did the tests and it looks like the mesial buccal cusp has got pain upon pressure, or using tooth sleuth or percussion or whatever it might have to be. It can't just be thermal sensitivity. It's got to be actually some kind of percussion sensitivity or pressure sensation that's causing it on one cusp but not others. That's cracked tooth syndrome. And that will, putting that in your clinical documentation, putting that in your notes, that's going to get the crown paid. Whereas just the photo with the cracks on it, it's just cracks. And so if it's not symptomatic, sorry about your luck. It may need a crown, but it's a thing that's an exclusion under most plans. And so they've got that all built in. And so that's the thing. When you're talking about, we need to get dental insurance to pay for X, Y, and Z, that is, there are plans out there that cover that stuff, but they cover it for the CEOs. They cover it for the people, because those plans are so crazy expensive that most people can't afford them.
Right.
We also talk about dental benefits, not having increased since 1960, whatever, right? We got $1,500, $2,000 max, and that's it. Do you know how many people who have dental insurance use all their benefits according to NADP? Do you know?
37%.
Nope. Way less.
Dang it.
Less than 3%.
Use the full benefit.
Less than 3%. So that's, from the payer's perspective, that's their argument. Well, less than 3% ever use their full benefits. Well, the thing is that the vast majority of people who have dental insurance either don't use it or only
maybe
use
the 30%ish, 37 is like actual use of benefit.
No, that could be. That could be
like where you
benefit.
have it and then they actually go to preventative
use
services.
it for anything.
Exactly.
The amount that max out is less than 3%.
That's probably true. I mean, I see that in my own practice.
Mm-hmm.
And especially if they have the benefit and they're using it appropriately, and we're doing preventative services and we're trying to catch stuff before they become the $4,500, the $10,000 treatment plan.
Absolutely.
Then we don't have to hit the maximum. We can do a couple of DOs and still be sub max for that month.
Preventive services and making sure that you're taking care of that stuff. And
right.
That's a little tip or trick, kind of as an aside, using the Caries codes, the 601 through 603. That is whether you have a moderate, a minimal, moderate, or severe risk of caries. And so those caries codes there that the Caries, it's not testing codes. What's the word? Gosh,
are those diagnosis codes?
They are diagnosis
or modifiers.
Codes. They're not modifiers, no, but they are. 601 is low caries risk. 602 is moderate. 603 is a high caries risk. And if you're actually doing that caries risk assessment, there it is. It finally came out of my brain.
Okay.
Caries risk assessment is essentially a form. You can download the thing from ADA. Okay. 3M has a good one. There's a bunch of them floating. There's one on our website. You're welcome to it. And it's essentially just a questionnaire. You're doing this and you're flagging those particular patients that are going to have a high caries risk. You can actually turn that in to the insurer. The caries risk assessment itself, I don't even normally charge for, or you can keep it as a minimal charge. You can do, $10, $15, whatever. But by doing that, it unlocks benefits under a lot of plans for patients who have a high caries risk. So I see 3rd and 4th adult prophys get covered. I see adult fluoride get covered. I see more frequent radiographs, more frequent evaluations, all that type of stuff either get some coverage or even get covered at a higher fee schedule than what you would have otherwise. Because insurers know that if they start throwing a little cash at these patients that have a high caries risk, that's going to keep them from having to pay out for a crown or a root canal or something else later on. And so it's on their benefit to make sure that those patients are getting a 3rd or 4th prophy a year, trying to keep this stuff under control, catch stuff when it's early, when it's easy to fix, it's cheap, it's good for everybody. So
and if you're doing that rapid test as well, then you're getting like real data. It's not even an assessment. You can categorize that to say strep mutans is high, pH is low. Like you're building a profile pretty
all those
easily.
saliva tests. Now we already have saliva testing codes that are laboratory based. You know, you're taking something, you're sending it off, they're checking it out and sending it back with a path report or whatever.
Right.
And so the new one is Chairside. Essentially, it's going to be done at the appointment point of service, POS, which means something else in my mind. But
yeah.
You know,
it means Chad Duplantis. Really quick, I've got a burning question.
Yes.
Because I get this question a lot because I lecture, and Chad might get this too, but for clear aligners. And so a lot of people that are in network that are getting the write-off for, we'll say they're doing Invisalign or whatever. And we all know the lab fees for Invisalign for most folks are around $1,800 to $2,000. And even the non-Invisalign companies, the lab fees are $1,000. I mean, they're not insignificant dollars.
That's right. That's right.
So let's say you're doing it for X company, your write-off is substantial. Your reimbursement rate's like $2,700 or something like that. And so there's been talk about, and some dentists are doing it, and they're just billing the 999 code, the ortho 999 code as an aesthetic upgrade. Some will at least, they're not going to cover it, but they won't say it's inclusive, which would then allow the doctor to pass that upgrade fee along to the patient. And some will kick it back and say it's inclusive, you can't charge it.
That's been around for a long time, doing the 999 as an upgrade, essentially. Yeah. And more, we're seeing that go away. It's essentially, as clear aligners are becoming almost the standard of care. I'm seeing more of that than arm wires and brackets in general practices these days. It's not being a separate covered benefit, but there's so many things that people don't code for that they could. Did you know that there is a code for the ClinCheck? Did you know that there is a code for the photo set? There's a code for the diagnostic casts. There's a code for treatment planning. All these things. There's so many different. There's codes for IPR. There's codes for all these kind of things that could be worked in to a treatment case, and a lot of them have reimbursement. If they don't have reimbursement, they may be a non-covered service where you can pass that cost to the patient. You're offsetting your write-offs by doing that. If you are an Invisalign client, the reason I was at that Invisalign summit with you the other day was because Practice Booster built out Invisalign's portal for coding and billing. And so you can actually find that, and it's free. It's if you're an Invisalign customer and have a Clin ID, you can go to practicebooster-align.com/align -start. I'm sorry, align-start.
They could have made that a little easier.
They could have
made that a little easier.
So, practicebooster-align.com and then align-start after the backslash. And so go in there, you're just putting in your practice info and your Clin ID, and you've got video courses, you've got forms, you've got coding cheat sheets. You have our entire 560-page admin book. It's on there as an ebook. It's all free. Invisalign paid us to give it to you.
That's awesome.
And so if you've got that, that's going to walk you through all those little extra things that you can code for and proper ways of doing billing to maximize your legal reimbursements. Okay. Yeah. I'm going to type in that URL later. Okay. Can I type that in chat? Will that show up?
Yeah.
Yeah.
And then we'll put it up at the bottom.
Okay. I totally will. I'll copy and paste it. It's in your chart. It's in your notes there too, guys. I gave it to you, but
we'll post
I can copy and paste that, but my screen will go blank while I do it. So I'll do it later.
He'll lose all connectivity.
I don't know where to put it, but if y'all want to copy paste it, you can stick it in there for somebody.
We got it.
Greg, I almost stopped you earlier before JB got on her clear aligner rampage, but I have a question for you, and I know that you are coding and not insurance. We talked about that earlier.
No, I do a lot of that admin too.
Do you feel? I just haven't been having this thought lately. Do you feel that AI has had an impact on the way that we code or the way that insurance reimburses? And what basically what have you seen that AI has done, and specifically Radiographic interpretation, AI.
It's a big topic. And go, so first off, over 81% of payers right now are using AI in some capacity within their company. The vast majority of them are using them at first for just processing the claims. Essentially, AI is looking at, hey, this is a Perio claim. Are there X-rays attached? Are there probing depths attached? Yes. Okay, I'm going to go send it on over to a person. Okay. No, I'm going to immediately kick it back. Okay. If it's submitted for a prophy and the patient has prophy benefits, they'll automatically, say yes and pay it without it ever seeing a person. If they don't have prophy benefits, they'll automatically deny it. So in that way, it's speeding things up. It's good. Okay. The use of AI is great as far as the administrative aspects of things. On the clinical side, okay, they're using Pearl, they're using Overjet, they're using Vidya Health, they're using these companies to look at your radiographs. And particularly for periodontal claims, this has become a thing as of late because they are looking for radiographic evidence of bone loss that is substantial. They're looking for 2 millimeters or more of bone loss around a tooth before they're going to say, yes, that is an area that's had actual bone loss. You can have a 5, 6, 7 millimeter pocket just because of swelling, just because of inflammation of gums, no bone loss. To be periodontal in nature, it has to have bone loss associated. And so a natural variance of about 2 millimeters from CEJ to crest of bone, that could be healthy. Okay. Anything more than that, they're calling it a potential disease process. And so they're measuring that. And so also think about this: garbage in, garbage out. If you're sending them some bitewings that you took, but you took them slightly at an angle, you foreshortened your image, right? Now that 2 millimeters of bone loss is 1.7 and your claim gets denied. Okay. So absolutely make sure you're getting a great 90-degree angle.
Or no bone at all.
Or no bone at all. Right. And so, yeah.
I get a few of those.
Right. And so the claims adjuster guys that everybody's getting mad at and screaming at over the phone, they're just dentists like me that had some kind of life change, and they still got to feed their family. So they're going to work for some company and they got to follow this book. They're given this book that says, hey, we don't pay on a perio claim unless there's more than 2 millimeters of bone loss. Okay. And so AI will flag these things. If there's not enough bone loss on those particular radiographs that you send in, it will flag it. It won't deny it. AI cannot make a negative clinical determination. Okay. It can automatically pay something if it feels like it's okay. But if it makes a negative clinical determination, that has to go then to a claims adjuster who makes the final call. All right.
That's really good to know.
And so
you're affirming so much of what I tell my team on a daily basis. And our front office staff, I always tell them, I said, insurance companies are checking boxes.
That's what they're doing.
They're checking boxes.
All got to be there.
Before we send a claim in, let's make sure the boxes are checked before they get it. Because if the boxes, if there needs to be 10 checks and there's 9, it ain't going to get paid.
That's right.
That's what we're seeing.
I spend a large amount of my time doing what I call revenue enhancement consults. That's where I get on with a practice for 3 hours over Zoom like this. And I walk you through the CDT code set. I start up at D120 and I go down to the bottom. Okay. We don't cover all the codes. I cover the ones that I feel are applicable or you need to know something about. I'll show you the code language that you're not aware of. Most people know the nomenclatures. They don't even know the descriptor exists and they're missing stuff. And if you're ever audited, that's going to come back to bite you in the butt. And what the claims criteria are and what the documentation has to be. I walk you through all of that for each one of these codes. I talk about what's going on in this. And then I also do fee rebalancing as a part of that as well. But that conversation on the phone, it's 3 hours. It's CE. It's pretty cheap. I usually get a 10 to 40x ROI on that thing.
I bet.
So it's a good deal for practices.
So, that's actually, Greg, let me jump in. That's actually how I got to know Charles Blair. That was something that I had engaged in with him. was a fee analysis, and of course, you know, we got into all the coding and everything. But it's incredible the difference that it makes to have your fee set appropriately. A 3% fee increase does not mean a 3% increase to your bottom line.
No.
It is exponential what setting the proper
And
fee.
I gotta tell you, first off, most of the fee schedules out there are way wonky. They're kind of crazy. They got a lot of stuff right and a lot of stuff wrong. So we have access to all the fee schedules basically that are out there. And so we take that data and we compile it. We put our own spin on it. We look at it, and then I custom go through and tweak. All right. Because I don't feel like you can do a 3% increase or 5% or whatever it is that you do annually. Well, if your fees are out of balance to begin with, you're just moving that out of balance up a little bit, but they need to be balanced to begin with. And so getting things where they ought to be in relation to one another, that's step one. And then from there, smaller increases on fees that are bread and butter things that patients see every day. Your prophylaxis, I don't want to go up 25% on prophy.
Right.
But by God, I can go up 25% on a reline of a denture that they don't know. They don't see that from one year to the next. And so it's kind of the bread and butter services, the things that are constantly repeated annually, patients pay attention to. The one-offs, they don't. You're able to do a much larger or substantial fee increase. And so I do all that. I do all that custom for practices and help people get it where it needs to be. So
yeah,
but
to
the
your
code
point,
training, the code training is, to me, the more important thing, frankly. It's learning how to actually comprehensively report everything you're doing, get reimbursed for all the bits and pieces that you can, document everything correctly so that if you're ever audited, it's not an issue. Know what the audit flags are.
Yeah.
All that, making sure all the verbiage, and starts on the clinical team. It's all about, did you capture the right intraoral camera image, and did you write the right keyword in the clinical chart? AI is scanning for that stuff. They're not asking for narratives anymore. They want to see the notes of the date of service. That is the only legal document that stands up to audit. And so docs, you got to be putting it all in there.
Yeah.
It's on you. It's your license on the line. And so, and it's you when you're audited. If the verbiage that you're writing in the chart is what's going to matter, which is huge. And so I want to be able to help.
Pretty soon, AI is going to help us write those notes too, Greg.
AI is helping write those notes, which is awesome as long as it's doing the right stuff.
Exactly.
I did a little test on AI recently, just out of curiosity.
I do one every day.
There you go. I took 30 some odd coding questions that we get kind of on a regular basis, that are common errors and things like that. I plugged them in to both, I tried it through Google, I tried it through Chat GPT, and of the 30 questions that I submitted, altogether, there were, I think it was 5 that were correct altogether. Only 3 were absolutely correct on both things. They each got like 6 or 7 correct, but only 3 of them were the correct on both answers. They were just wrong. I mean, it was less than it was not good. You know what I mean? And so for some really straightforward stuff, it's true, but AI and Google, they're all trained on stuff that's out there and has been out there. And so it's looking at outdated information. These codes change every year. There's been 200 changes in the last 5 years, 60 coming this coming year. And so they're significant. And I was about to get to it, but all of the sedation codes are changing next year. I mean, down to nitrous. Every single sedation code is changing in 2026. If you do it in any way, shape, or form, conscious sedation code is being deleted. It's being replaced. There's a lot of great information. I'm going to be doing a live coding webinar Tuesday, December 9th. It's free. It's at 1 p.m. Tuesday, December the 9th, at 1 p.m. I'd love it if you guys would participate in that and listen to it. And so I'll be going through all the code changing and everything you need to know. It's a 1-hour deal. And so hopefully that'll kind of set you straight on all that. But everything has now kind of been broken down to it's all based on the ADA's 2016 guidelines for the use of sedation and general anesthesia by dentists.
Yeah.
That's a document that's been out there, and that divides it up into minimal, moderate, deep, and general sedation, and also by method of administration. So enteral versus parenteral and things like that. So you have to know what that stuff means, and we'll be happy to kind of go through all that and talk about it.
Hey, Greg, that webinar is just for sedation codes?
No, it's for all of the code changes for 2026. I'm going to go through all 60 changes, and covering that in 1 hour. I'm going to go through the changes that there's a big chunk of them, honestly, that are very specific to prosthodontists who are doing reconstruction after cancer surgery. I'm not going to spend a lot of time on that. Okay.
Yeah,
There's maybe 2-3 people out there that would even apply to, but the rest of the codes absolutely are applicable to just about every general practice. And so, those sedation codes, that's huge. I mean, every single one of them changing. And so that's a big deal. And the other big one that you touched on too, JB, was scaling of a single implant in the presence of peri-implantitis.
Yeah, that's big.
We had a code added a year or two ago for scaling in the presence of mucositis. And we already had some surgical codes. If you're flapping it, there was a code. If you're flapping it and doing a bone smoothing, there was a code for that. But there were no non-surgical, kind of SRP equivalent. You can't scale and root plane something that doesn't have a root.
Right.
It's an implant. And so that's SRP codes are specifically for teeth. So we now have this code that's the 6081 code that we got last year is for mucositis. That's essentially inflammation, puffy gums, gingivitis. But this new one's going to be for peri-implantitis. So a non-surgical treatment for peri-implantitis. You're able to code this right on top of the 43, 41, or periodontal codes that you're doing. So
can you code that on top of a prophy code? Because those aren't often they're not always perio patients. It's just that one location has lost enough bone, or you know what I mean? Like it can be very specific to titanium alone and not.
Right. Absolutely. The only issue with doing that, and you can, those are two separate things. You can do it as a standalone, as a matter of fact, but literally the descriptor on both of those codes, the new code and that 6081, says this procedure not performed in conjunction with D1110, 4910, or 4346.
So you just bring them back, or they have to
just can't do the same data service.
Yeah.
And I wish it wasn't that way, but I don't get that choice. You know what I mean? We have to go by what ADA says, not by what I wish ADA said.
Yeah, sure.
So.
Well, Greg, this is amazing. I could sit and talk to you forever. Like I just want to sit and absorb this more and more, because I mean,
I just did 6 hours in San Antonio last weekend, and it was Day of the Dead. That was really cool, going out and seeing the whole Dia de los Muertos celebration going on. But spent 6 hours talking. We didn't get anywhere near through everything we could have talked about. So I mean, we could sit and do this forever. And it's great. I do have a discount code for you guys.
Yeah,
I was going to ask you how they get in touch with you, and
I wanted to make sure. Yeah, dentalcoding.com. I mean, you can't get any more basic than that. Dentalcoding.com. That's going to point you in our direction. Everybody that's a listener out there, you can enter the discount code, all caps, DINKS, DINKS 2025. That's this year, not next. DINKS 2025. It's going to get you 10% off of all the print books. And so you're welcome to do that. Now, we do have some bundles out there. Those are already 15% off if you buy the coding and the admin book together. So it doesn't apply to those, but it does apply to the single print books. There's the online system and everything, and our consulting services. All of it's on there. So dentalcoding.com, my podcast, all that you can access through there as well. So,
and I can personally vouch for the consulting services,
because
for sure. What that did for my bottom line, having a go through code by code, and just understanding and having more claims paid, charging the right fee. My point was 3% is not 3%. If you go up 3% on a specific fee, what it does to the bottom line is exponential. So, and it just took me doing that to understand that.
Man, and I've yet to do one of those that didn't pay for itself multiple times over, and you get CE for it. So, no brainer in my mind.
Well, awesome. Thanks for being with us.
Absolutely, guys. Thanks for having me. I appreciate it.
And
Great conversation.
We have a lot more to do with you. So,
bring it on.
Yeah, we'll be seeing a lot of each other.
I would walk cautiously. That's how I got here.
Yeah.
You got roped in, did you? Yeah. I get it.
Chad, what do you say? Close us out.
I think there's so many great things about Greg, but I'm going to go ahead and throw out there. I think one of the things that we need to have you back for is that you really represent how when life throws us a curveball, you can pivot and do something differently. And you have not only done something differently, but you've done it pretty damn well. So kudos to you, my friend.
Oh man,
I would love to have you back for a podcast, like maybe with Greg Wu, who had to pivot because of a stroke, and you had to pivot because of an issue with chemotherapy, because there are people that, I'm sorry, I'm just going to say it, shit happens to. And you got to figure out what you're going to do with yourself, because all you know how to do is be a damn dentist, okay?
My motto here, my thing is, you can't control the things that happen to you sometimes, but you can always control the way that you respond to them. And so your attitude going forward, the choices that you make, it's huge. It's huge. And so you can't control what happens to you, but I never thought this is what I'd be ending up doing. I mean, if you'd asked me 12-year-old, what do you want to be when you grow up? It wasn't this, so you
I'd like to be a dental coding specialist.
Right, stay-at-home dentist. Yeah, no, that's not at all what I was thinking. Even, a couple decades ago, not what I was thinking. But here we are, and I'm not just, surviving, I'm thriving, man. It's good. It's good. Life is good, and I couldn't be happier.
Man, that's what people need to hear. So we want to have an episode on that. Secondly, we'd love to have you back and do a webinar on dental coding. I think we can definitely arrange that. But dude, your knowledge is so vast. I want everybody here to tune in on December 9th. I would love for you to put a post on our Facebook group, and we'll share it on Insta and on Reel or whatever. But please put a post as to what that is, because my front team is tuning in.
For sure.
It'll be it's through Dental Zing, which I don't know if you know what that is, dentalzing.com. It's everything dental from A to Zing is but it's dentalzing, zing.com. And that's a platform that we have as coding our webinars on demand, things like that. And so, but this one's a freebie, and it's going to go over all the changes for 2026. So,
well, Greg, I'm embarrassed that it took us so long to get you back on the show, because
what was it, 2022?
Yeah, this has to be an annual thing now.
I think it's got to be at least annual. And from the bottom of our hearts, we thank you so much for actually agreeing to be on here. You're a wealth of knowledge, and it's an honor to call you a friend. And I'm sure I'll see you rocking out.
Whatever the next meeting is, we'll be there. And so we'll see you soon.
We'll see you soon.
Thanks
for being
so
here
much for having me. I greatly appreciate it.
Love it.
Thank you, Greg. Good night, everybody.
Good night.
Night.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.